Good afternoon, everyone. I'd like to welcome you all to our keynote speaker for today. My name is Sister Mary Jo Stein. I'm a Catholic sister in the Congregation of the Daughters of Charity of St. Vincent de Paul, and I serve in healthcare as a family nurse practitioner. I have the privilege today to introduce our keynote speaker, Barbra Mann. She has extensive experience as a nurse, historian, and educator. After obtaining a bachelor's degree and a master's degree in nursing from 2 Texas universities, she earned a PhD in history from the University of Notre Dame. Her research illustrates the gendered story of hospital establishments and the nursing profession, and has borne fruit in the publications of 3 books on the history of Catholic healthcare. Her award-winning book, Unlikely Entrepreneurs, Catholic Sisters and the Hospital Marketplace, 1865 to 1925, a book published in 2005, integrates history and nursing practice to inform how America's 2-tiered approach to health delivery, that is, private and public, served a diverse American populace. Her second book, American Catholic Hospitals, A Century of Changing Markets and Missions, published in 2011, analyzes the rather invisible role of Catholic sister nurses as leaders of the largest not-for-profit healthcare systems in the United States, and the tensions that have developed as religious institutions attempted to directly shape health policies in a diverse milieu. Her newest book, entitled Into Africa, A Transnational History of Catholic Missions and Social Change, published in 2015, explores the intersection of religion, medicine, gender, race, and politics in Sub-Saharan Africa after World War II. Barbra Mann is currently the director of the University of Virginia's Nursing History Center in Charlottesville, Virginia, and has most recently been asked to serve on the UVA President's Commission on Segregation after the Civil War. Barbara recently shared with me that she is planning on retirement in May of this year. She comes to us today from her home in Austin, Texas, where she has been remotely carrying out her position at UVA during the pandemic. She brings her insights as a nurse historian to her conference topic today, Catholic Sisters in Healthcare, Conflict, Entanglements, and Crossovers in Medicine, Nursing, and Religion. As we can see, this topic fits in well with this Catholicism and healthcare across the globe, this conference this weekend, this global conference. And as a Catholic sister in healthcare myself, I am eager to hear Barbara's reflections. After this keynote address, we will have time for a question and answer session, and we invite you to submit any questions you have in the Q&A box on your screen. So now I turn the screen over to Barbara.
Well, I want to begin by acknowledging the people in this virtual room. And I thank everyone who's been working so hard to put this program together. As Sister Mary Jo said, I'm a nurse and a historian. And as we draw this conference to a close, I'm going to ask you to look back before we can move forward. We've had wonderful sessions on narratives of health and illness, on traditional and non-traditional healing. We've heard about Catholic work in different countries such as Ecuador, Honduras, Korea, Africa, and many other places. We've also heard about conflict. Sometimes this conflict has resulted in violence. We've heard about the critique of biomedicine and about the critique of politics. And today I want to give several of these issues a history. I'll focus on the interconnected history of medicine, nursing, and Catholicism by using Catholic sisters as a case study. Typically, storylines of conflict have persisted in the historiography of these topics. But in my research, I problematize conflict narratives with histories of entanglement and crossovers between medicine, nursing, and religion. My thinking has been shaped by years of research on Catholic sisters in hospitals, including interviews with sisters and studying in various archives. I want to acknowledge sisters from archives in the UK, in Ghana, Ireland, and the United States. As well, I benefited from the wonderful intellectual background when I was a student in the history department at the University of Notre Dame, and I still received their support. In my early reading of the historiography of hospitals, I realized that there was no analysis of the many Catholic hospitals that grew up across the United States and the world. In this paper, I'll begin by discussing sisters' healthcare establishment in the United States, and then move to their work in Sub-Saharan Africa. And then I'll bring it back to the United States in the end. In the 18th and 19th centuries, the few hospitals that developed in the United States were established by Protestants. Now, I'm a hybrid. As Sister Mary Jo said, I'm a historian, I'm also a nurse, and when I did my dissertation, I found that Catholic sister nurses, the women of the church, were the ones who established and administered the Catholic hospital system in the entire country. They built institutions and created services for the poor, long before the emergence of the modern hospital and scientific medicine. In fact, the woman-centered, nurse-based entrepreneurship of Catholic sisters had a distinctive effect on the character of today's American healthcare institutions. Now, this is a picture of Sister Ignatius Farley. She was an Irish immigrant who came to the United States just before the Civil War, and she worked as a nurse in that war. So I'm interested in how sisters like Sister Ignatius became this. What you're viewing are the owners of the Catholic hospitals across the United States in the 1920s. And this is two halves of the same picture. And you can see that most of them are nuns. Most of these women were also European immigrants, and they were mainly Irish, some German, some French, and most of them were nurses. When they first arrived in the United States, they had no money. Furthermore, the public face of Catholic authority undoubtedly has been male. It's ironic then that most Catholic hospitals in America were established and originally managed by women. They could not count on the church for aid, yet these sisters did things that most of us can urgently learn from, particularly around questions of power, engagement, and change. Historically, Catholic sisters have had a mission to care for the sick, the injured, the aged, and the dying. In the process, they found multiple connections between biomedicine and religion. In the 17th century, St. Vincent de Paul and St. Louise de Marillac's Daughters of Charity were going out into the streets of France to do nursing. Moving to the 19th century, sisters established hospitals at a time of rapid economic development in Europe and elsewhere. Famine and religious persecution led many Europeans to immigrate to the United States, while the United States had available jobs. It also had available land. By the 1860s, the total number of Catholics in the United States had doubled. Church leaders sensed that this growing Catholic population had only a few spiritual institutions, which included hospitals, and the sisters led in hospital establishment. As sisters expanded their health care in America in the wake of immigration, they faced Protestant anxieties over Catholics' obedience to the Pope, which Protestants thought was incompatible with Republican citizenship and religious freedom. Catholic leaders counterattacked this nativism by attempting to demonstrate the church's compatibility with American democracy. Because of the prevailing anti-Catholicism, Catholics formed strong attachments to their own institutions. While Protestant growth occurred particularly in the southern regions of the United States, Catholic European immigrants predominated in eastern cities such as New York, Boston, and Philadelphia, and Midwestern cities such as St. Paul, St. Louis, and Chicago. The Catholic Church was in the minority in Texas and Utah, but these areas attracted many immigrant miners and railroad workers from Catholic countries who were potential American Catholics. And Texas had a large Catholic Hispanic population. Catholic sisters went to all of these places. Wherever they went, they renegotiated dominant notions of what being a sister nurse meant as they navigated among an array of representations, from nurse to hospital administrator to woman, to religious profession, to a religious person, or to a professional practitioner of scientific medicine. They would never have succeeded in the hospital marketplace had they not demonstrated the flexibility to adapt. This adaptation resulted from the standpoint of making connections with religious and secular leaders and with people of other cultures. Sisters eventually established their own nurse training schools at the turn of the century. But before that, they received on-the-job instruction in the care of the sick from doctors and experienced sister nurses. Their religious constitutions articulated how the sick were to be treated, what daily schedule sister nurses should follow, how they should relate to physicians, how to care for the dying, how they were to prepare food, and how they were to prepare medicines. They incorporated various healing practices associated with regular medicine, while also carrying out devotions and rituals, such as devotions to the saints and the Virgin Mary. In 1823, nuns first began staffing hospitals in the continental United States at the Baltimore Infirmary, where they charged a small fee for admission. University officials asked the Sisters of Charity from Emmitsburg, Maryland, founded by St. Elizabeth Seton, to staff the infirmary. In the process, sisters had to construct a kind of nursing and hospital management that focused on accountability, skill, and flexibility. In the turmoil of immigration, sisters contributed to the production of something new, the modern hospital and the modern nurse. Sisters' prayer life, their business acumen, and their healthcare ministry intertwined as they worked in the hospital marketplace. Now, other scholars have made similar arguments. Siobhan Nelson, Carol Coburn, Maggie McGinnis, and Bernadette McCauley. I want to credit all of these scholars. We've all written about sisters in healthcare, and all of us dispel the notion that these sisters were separate from the world. Our work reveals conflicts, but also adaptations in nursing and hospital development as secular society changed. For example, the American Civil War from 1861 to 1865 was a defining event for the Catholic sisterhoods. And this is a picture of a monument. It's called the Nuns of the Battlefield. It's outside a church in Washington, D.C. 600 sisters from 21 different communities nursed in military hospitals, U.S. Navy hospital ships, prisons, and improvised hospitals. Other sisters converted their own hospitals into Army facilities. Most women nurses were untrained, but some of the sisters were trained. For example, the Sisters of Charity in Emmitsburg, Maryland. They had been educated by Mother Xavier Clark, who wrote Instructions for the Care of the Sick in 1841. Mother Xavier was superior of St. Elizabeth Seton's sisters in the United States from 1839 to 1845, and she wrote this booklet for sister nurses. Her instructions were an addendum to a part written by a priest in 1796, and you can see that. And her instructions are at the back of this book. Mother Xavier gave detailed instructions on prayer, but she also taught sisters how to give medicines. They were to keep them covered to prevent evaporation, avoid mixing them, know the correct doses, and use clean utensils and clean water in all the preparations. We still teach nursing students to do this. Mother Xavier taught that the sisters would be in charge. The experienced sisters should know everything so that they could guide the less experienced sisters and teach the men who are caring for male patients. While the sisters' model emphasized self-abnegation, respect, and devotion, the nurse was also to seek knowledge and ask questions. Significantly, Mother Xavier taught her sister nurses to respect both bodies and souls, and not to be like secular nurses who worked for money. Selfish intentions were in opposition to any calling of a religious sister. Now, those of us who study Catholic sisters acknowledge Florence Nightingale as legitimizing nursing as a respectable field for middle-class women. But it was the sisters' nursing that became the model for the modern nurse, long before Nightingale came on the scene. Sisters also worked with the government in ways that became innovative models of church and state working together. For example, in 1864, the Sisters of St. Joseph in Wheeling, West Virginia, contracted with the Union government for $600 a year for the sister nurses to care for soldiers at their hospital. The superior, Mother de Chantal Keating, shown here, was a young Irish immigrant who had come to America during the Irish famine years in the 1850s, and she strongly emphasized economic security. On February 8, 1865, Mother de Chantal personally appealed to authorities in the War Department in Washington, D.C., when the Army was delinquent and paying rent to the sisters for the use of their hospital in Wheeling. She presented her accounts and certificates. She sat outside the door. She did not leave for 2 weeks until the quartermaster informed her that all arrears would be paid. She and her sisters had a strong religious commitment to their work, but their entrepreneurship led them to expect the government to uphold its end of the deal. Mother de Chantal's perseverance and significant wartime experience was an example for many. Wartime was an especially important time for sisters to demonstrate their skilled nursing care, and their work helped change and helped enhance the general public's perceptions of Catholics in the United States. After the American Civil War, Catholic hospitals in the United States grew alongside other hospitals during a period of scientific expansion. But from the beginning of sisters' hospital establishments, they had an expanded idea about illness and treatment. Now, this is a photo of the Sisters of Charity of the Incarnate Word in San Antonio, Texas, along with the Protestant physicians with whom they worked. There were few Catholic donors at the time, and sisters had to charge patients from the very beginning of their hospitals. And sisters did not dwell on the need for Catholic doctors in their hospitals because they partnered with as many physicians as possible who had to bring in the paying patients. The doctors brought in the patients. The sisters ran the hospital, but the doctors brought in the patients. So both Protestant and Catholic doctors and sisters depended on each other to maintain medical accreditation, financial viability, and religious authority. Also, by the early 20th century, the germ theory had been expected, and doctors became more disease-oriented. While they could more skillfully diagnose a problem, they could not cure most diseases until the Second World War and the arrival of antibiotics and other wonder drugs. Doctors could bring relief, but increasingly this was being replaced by a narrower scientific orientation and institutional structure of modern medicine. By contrast, from the very beginning of sisters' hospital establishments, they had an expanded idea about illness and its treatment. They certainly accepted the values and orientations of modern American medicine, but they also believed in supernatural causes and treatments based on a long-standing Catholic devotional culture. They developed a space in the United States where a specific, socially beneficial type of care could be provided and purchased. These sisters brought into being new hospitals with different economic models, those in which authority depended not on male physicians or church leaders or even state support, but on the ability of women religious who convinced other people to have confidence in the Catholic hospital that they created. In the process, sisters assumed full financial responsibility of their institutions. They served as board of directors, administrators, nurses, school of nursing leaders, X-ray workers, pharmacists, and they built collaborative networks with influential sponsors, many of whom were non-Catholic. As nursing and medical standards increased and science and technology expanded over the course of the 20th century, the sister schools of nursing and hospitals kept pace. This included requiring the newest equipment, more intensive coursework for nursing students, many of whom were not Catholic, higher admission standards, and licensure examinations. Now, let me add here that the Alexian brothers were also nurses and hospital administrators, but the vast majority were sisters. I like this particular picture. It's an operating room of the Franciscan sisters in the 1920s. I like it because it shows the blend of what I call medical and sacred space. Sister nurses are in their religious habits, while at the same time a nun is giving anesthesia. Nursing students are likely present, and they and the physicians are poised to do scientific surgery. So this photo also supports my argument that Catholic hospitals were both medical and religious spaces. In 1915, sisters and priests formed the Catholic Hospital Association to work toward greater standardization in their hospitals. The American College of Surgeons also adopted certain standards for hospitals to obtain approval. All hospitals were doing this to maintain accreditation, and sisters kept up. But the Great Depression created emergencies that caused a flood of legislation that affected all members of society, including hospitals. The poor economy and expanding demands for free care led different hospital associations and administrators to work together for health policy in the political arena. They became avid proponents of the value of private hospitals, such as Catholic hospitals, as equal partners with government institutions. Resolutions asking for government aid were passed at the 1934 Catholic Hospital Association Convention, but money could be accepted only under one condition. Federal relief to hospitals did not mean federal control. We still have these tensions going on. Implicit in the 1934 resolution was the fear that the government might challenge hospital leaders' authority by becoming more involved in management issues. Eventually, Catholic and Protestant leaders secured a ruling to allow government employees to be admitted to private hospitals with reimbursement from the federal government, but without significant government regulation. But real success in health reform did not come until the mid-1940s. And by then, Father Alphonse Schwetala, shown here in front, was the Catholic Hospital Association president. In 1945, he and representatives from the Protestant Hospital Association and the American Hospital Association for the first time joined together to sponsor a bill that they themselves helped develop, culminating in the Hill-Burton Act, which provided federal grants to states for the construction of hospitals and health centers. In return, hospitals agreed to provide a reasonable number of free services to people unable to pay. Significantly, the bill restricted the government's role to determining how funds would be distributed to the states, which meant no strings attached. And the Hill-Burton Act was signed into law in August of 1946. Now, this photo shows Catholic sister nurses. Some of them were students with Father Schwetala as they were coming out of a building where they had just met with President Truman. This was a great example of church and state working together to solve a problem. Unfortunately, the Hill-Burton Act maintained separate but equal hospitals. It did not demand desegregation of hospitals as a prerequisite for getting federal dollars. That didn't come until Medicare and Medicaid in the 1960s. But after World War II, Catholic leaders did not yet embrace the view that everyone had a basic human right to health care, even through the government if necessary, and I'll return to this later. But now I want to move on to sisters' work in Sub-Saharan Africa. As the secular scene in the United States was changing and Catholic hospital leaders were becoming more involved in politics, so the world was changing. Following World War II, national identities and international alliances were shifting rapidly, and many colonized nations found courage and opportunity to move toward independence. In Sub-Saharan Africa, as the voices of independence grew louder, British and other colonizers reacted by moving out in droves. Consequently, indigenous populations struggled to realign their countries and begin the arduous process of self-rule. Catholic women's religious congregations, whose work in Africa had been hampered by World War II, now saw themselves playing a supportive role in this transition process by expanding their medical missions. They did so in the context of an accelerating Catholic missionary movement. In the 1950s, there were more foreign missionaries in Africa than ever before. This is a picture of Mother Anna Dangle. Under the leadership of Austrian-born Mother Anna, the foundress of the Society of the Catholic Medical Missionaries, or the Medical Mission Sisters, sisters established a new position for themselves that combined religious commitment and medical science. By the mid-20th century, Catholic sisters were being educated to be scientific practitioners, and they were convinced that they could bring established biomedical knowledge and therapeutics to the missions. They could bring greater healthcare access as one answer to an uneven distribution of hospitals. Indeed, the Catholic Church provided a structure for women and religious congregations as vowed celibate women to obtain a medical education and eventually to cross national and international borders as they developed care networks all over the world. Mother Anna and others had worked with the Pope to change a centuries-old policy that had prohibited Catholic sisters from practicing medicine. Now, they could do nursing, and that's what they did in all the years before that. But after 1936, they were able to become surgeons, midwives, and obstetricians in the missions. This was new. They worked alongside nurses in new initiatives, and for the most part, embraced the power structure of the Catholic Church and what it could provide them. Their personal negotiations of their religious and gendered identities in secular medical schools and later in their mission hospitals reveal the possibilities of professional roles for Catholic sister doctors, nurses, and midwives to bridge international boundaries. Now, while the sisters could study nursing in both the United States and Europe, American sisters had to go to Europe for midwifery training due to restrictions on that practice in the United States, and that's a different history. Some sisters from colonized areas, such as Nigeria, were able to go to Europe, including Ireland, to qualify as nurses and midwives. Others trained in different missions congregations, in the schools of nursing in the missions, and midwifery in the colonies. And sisters went into these areas with the idea of training local practitioners as midwives and as nurses and lab workers to do the healthcare worker once the sisters were able to pull out. So in her 1945 publication, it was called Mission for Samaritans, Mother Anna Dangle outlined a particular framework for mission work that combined religious commitment, medical science, and politics. She saw it as, quote, a branch of missionary work through which skilled medical care is given to the sick and poor of mission countries as a means of relieving their physical suffering and bringing to them a knowledge and appreciation of our faith. Yet one of the reasons she gave for medical missions was as an act of restitution as well as charity. She wrote, again, this is in 1945, it's the tremendous debt which we, the white race, owe to the peoples subjected and exploited by our forefathers. Furthermore, the sisters would care for all with whom we see suffering and sick, even if we know they will not therefore accept our faith. End of quote. Although Mother Anna recognized that missionary priests and sisters had worked for centuries in relieving the sick, what was new for her religious community was organized, systematic medical care by people who've been trained in the medical field as doctors, nurses, midwives, or technicians. She was convinced of the superiority of scientific knowledge, and she wanted to make it available to others. Mother Anna's congregation, the Medical Mission Sisters, was one of the first groups of its kind in the medical field in being both professional and religious, and to work as physicians, surgeons, and obstetricians. But disagreements on the nature of mission legacies are central to historians today, and we've had wonderful papers on this. Many see missionaries as agents of British imperialism, and indeed, when they first went to Africa, nuns did align with British colonial authorities to get their foot in the door. Although it took a period of soul-searching and questioning of the very idea of mission, social and economic realities of the people with whom sisters worked became part of the mission focus, as did a greater respect for African cultural practices. From the beginning of their work in Sub-Saharan Africa, Catholic sisters focused not only on acute care, but also on public health. And this shows a medical mission sister in Uganda. They called it going on safari when they would go out into the bush areas to do clinics. This caused many challenges as they worked in environments that were different from their own backgrounds in Europe or America. Although sister nurses, physicians, and midwives were well trained in colleges and universities, when working in the bush or holding clinics during wartime or other periods of violence, they faced new challenges. Because physicians were in short supply, often sister nurses took on roles that physicians carried out in Europe or the United States. Just as in the United States, Catholic sisters' medical practices in Africa incorporated both science and religion. Even though they performed surgery in sterile operating rooms, sisters also included religious feasts, processions, and rituals in their hospitals, and they celebrated holy days. Mission hospitals were also sites where one could witness a variety of healing practices. One hospital administered by the American Maryknoll sisters was in Tanzania. In 1949, a sister delivered a premature baby who did not thrive. And after performing life-saving measures, the sister doctor eventually gave up and baptized the infant. Yet she had also allowed an Indigenous practitioner into the delivery room. According to the sister, this person beat some sort of a cooking pot, which she held over the baby's head, and chanted a song to ward off the evil spirits. Well, soon the baby started breathing. Now, blending of cultural practices was not common in Africa in the 1940s and 1950s, and sisters strongly believed in the superiority of their scientific medical practices. They also believed in miracles. In this case, the sister attributed the baby's survival to the baptism rather than the work of the Indigenous healer. Sisters also faced ethical challenges as their work intertwined with political movements. As medical missionaries in Sub-Saharan Africa, sister doctors, nurses, and midwives had a major role to play in healthcare delivery during war-torn areas. And we heard about some of this earlier in one of the earlier presentations today. Now, this is a photo of Sister Dr. Pauline Dean. She was a medical missionary of Mary from Ireland, and she was a pediatrician. She worked in Arua Akpan and other places during the Nigerian Civil War. The war lasted from 1967 to 1970. 1 million people, mostly unarmed civilians, including women and children, lost their lives during this Civil War. Irish missionary doctors, nurses, and midwives, sponsored by the Roman Catholic Church, provided wide-ranging humanitarian relief and medical care during this time. The medical missionaries of Mary had come to Nigeria from Ireland in 1937 to do both mission and medical work. In the 1960s, however, they shifted their understanding of mission away from conversion of souls toward humanitarian relief. Catholic sisters had come to Nigeria during the colonial era, when Christianity was the religion of the colonial powers, and the missions had a privileged position. Irish priests and sisters aligned with British colonialists, and the sisters were hardly ecumenical. Over time, however, they learned the local language and they acculturated to their surroundings, and this caused many tensions that exacerbated during periods of revolution or civil war. The Nigerian Civil War led to a public health emergency when a segment of the Nigerian population became displaced in an area renamed Biafra, and it's shown here in the lower southeast area of Nigeria. Food was cut off to them. The Catholic Church was one of the private agencies that played a significant role in the Civil War. Although they had made little impact in the northern part of Nigeria with its Muslim majority, Catholic missionaries were more successful in the southeastern region, particularly among the Igbo or the Igbo population. For the Irish, Nigeria was the centerpiece of their religious empire, with more Irish missionaries in Nigeria than anywhere else in this part of Nigeria than elsewhere in the entire world. By 1965, the southeastern area had over 2 million conversions. The Irish also made great inroads in education and healthcare, where the British colonial state had not played a large role, and that's one reason the British welcomed the Irish priests and sisters to do the teaching and to run the hospitals. Nigeria was formed in 1914 when Britain joined the two northern and southern protectorates, and it received full independence in 1960. Yet ideological and social differences between the Muslim North and Christian East were huge. The Civil War that began in 1967 was between the Eastern region, again renamed Biafra, and the rest of the country. Biafra declared itself an independent state, which the federal military government of Nigeria regarded as an act of illegal secession. And the Federals fought the war to reunite the country. But 1 million people had fled to the east. And by April 1968, Biafrans had flooded into a landlocked enclave surrounded by federal forces who blockaded all the roads. Western nations were unwilling to violate Nigeria's national sovereignty, and they did not channel assistance across the border. While most Protestant organizations fled, the sisters and many Irish priests made the crucial decision to stay in Biafra. The 30-month war ended in 1970 when the revolt collapsed. One important document I found is a diary by Sister Dr. Pauline Dean, whom I'd shown you earlier, the medical missionary of Mary. As I said, she had worked at St. Mary's Hospital in Uru Akpan during the war. Sister Pauline wrote her diary from January to September 1968. It was during this period that her hospital was in the middle of the conflict. St. Mary's had begun in 1952, and at the time of the Civil War, it boasted 150 beds, a large surgical clinic, and a training school for midwifery. In her diary, Sister Pauline gave eyewitness accounts of aerial bombardments of her hospital, people being killed, roadblocks established by soldiers, and the disease situation in the refugee camps. The diary provides a vivid account of the most severe health and nutritional problems of the war's effort. Her first entry on January 23rd was an acknowledgement of the food problem. She said, "Food was scarce, so we started to farm, planted pumpkin, melon, and okra." On January 28th, she noted the turmoil of the region. "Plane and 2 thuds in the outpatient department. I did not hear because of the screaming children." On February 19th, she wrote, "Bad day trying to do male ward, children's ward, and 2 clinics. Head just doesn't work after 1:30 when working at such a pace." February 20th was another bad day. And on the 21st, she was, quote, "up at night from 2 to 5 a.m. And the next day she faced 108 patients as the only doctor. In the eastern region, where the military operations were the most active, farming could not take place and famine resulted. Some of you may remember those pictures. Some of you, if you're older like I am, may remember the Life magazine pictures of Biafra and the horrible pictures of the children with the kwashiorkor showing on that. An international ecumenical airlift began operating in violation of Nigerian airspace and without Nigerian authority. This airlift defied the federal blockade, often under gunfire, and it flew in medicines and food to Biafra, despite the fact that the Nigerian government had banned outside flights. The airlifts, though, were the only remaining lifelines for those in the eastern area. Now, the public face of the Nigerian Civil War really was of either the starving children or of the priests and some of these Nigerian workers who ran the airlift. But women played key roles in relieving suffering as well. Indeed, the sisters had a key resource on their side, Nigerian sisters in their congregations who could maintain the hospitals after the expatriates left. This photograph shows Sister Joseph Teresa Aguissieri. She was a Biafran Holy Rosary sister, and she's caring for a patient at a feeding station during the war. I really like this slide. Again, it shows the blend of religion and science, and she is a religious sister. In her habit, she's also working at a medical clinic, but she's working with a woman from Biafra who has brought her baby to the clinic. And the baby, it's sort of hard to see, but the baby has been covered with white chalk. And that was an important, a traditional healing measure that Nigerians use for their own children. I really like this slide because it shows the local response of Nigerians caring for themselves. It shows the response of not just the nuns, but also the mothers, the local people. And again, a blend of Catholic and biomedical and indigenous healing. The role of the Christian churches during the war was ambivalent, and churches supported both sides. In the process, the Catholic Church's role in the conflict caused considerable political controversy. The Nigerian government was hostile to the priests, the sister nurses, and the physicians, and other relief agencies in Biafra, arguing that they prolonged the war by feeding the enemy. To the government, this work was illegal. The Catholic Church was meddling and aiding rebellion. The federal government eventually expelled 300 priests and 200 sister nurses and physicians from the country. Only a few were invited back later in the 1970s. Yet, as much as the Irish sisters tried to project an objective image, in reading their documents, it's not difficult to see where their loyalties lay. As they saw their people dying, their voices became more critical, to the extent that their humanitarianism reflected their identification with the vulnerable Biafrans. Then it became political. For the Irish sisters who thought the suffering would be greater if they did nothing, the consequences of their involvement in the political struggles were huge because they lost their hospitals. When the Irish medical missionaries of Mary were expelled from Nigeria, however, what was lost for them became an opportunity for Nigerians. The Catholic Church had been slow to indigenize its institutions. With fewer white expatriates in the church after the war, more Nigerians were ordained as priests, and Nigerian sister nurses, physicians, and midwives also continued to work. And so you see here Sister Veronica Akpan and Sister Agnes Maria Essien. They were both medical missionaries of Mary, and they were nurses, and they remained after the war. Africanization of church institutions did, in fact, increase after the Civil War. Now, the Nigerian story is a conflict narrative, but I will not end with this. An example of an entangled history and one of crossovers can be seen in the sisters' work with African indigenous healers. When sisters first came to Africa in the 1930s and 1940s, they were critical of indigenous healers. But by the 1970s, sisters and other healers began mutually exchanging knowledge. Now, this occurred in the context of an expanded primary healthcare endeavor, with preventive nursing and medical strategies increasing. The sisters also began allying with national organizations such as local and state ministries of health, and global actors such as the Christian Medical Commission and the World Health Organization. As early as 1962, Sister Dr. Margaret Mary Nolan, a medical missionary of Mary who worked in Nigeria, wrote about indigenous healers, quote, "The native doctors have many useful, powerful leaves and herbs at their disposal. In many cases, native treatment will save a life through controlling hemorrhage or relieving pain and preventing shock. The ill effects seen from these raw drugs, we presume, arise simply because the dosages have never been studied. All this leaves plenty of scope for research workers." As well, Sister Rose Kirschbaumer, a medical mission sister and a nurse midwife in several countries in Sub-Saharan Africa, recalled that as the years progressed, she said, "We would have groups of traditional healers get together as the countries then began to recognize that there is some good in traditional medicine. And what you have to do is try to eliminate what isn't good and support what is good." By the mid-1960s, sister nurses were incorporating some indigenous healing measures into their own practice. The Merino sisters in Tanzania ran a clinic that had what they called a snake stone. They had learned this treatment from another local doctor. Poisonous snake bites were common, and when a patient came with a problem, the sister nurses incised the bite to get it to bleed, and they had learned to treat this stone. They cleaned it and washed it and heated it, and then they pressed this stone and this stone into the blood of the area of the bite for an hour until it fell off. The therapeutic effect was that it absorbed the poison, and the sisters marveled at how the patient's pain was relieved soon after. It proved effective therapy for spider bites and bee and wasp stings. More crossovers occurred in Ghana, where the medical mission sisters worked extensively with public health workers in primary health care. The sisters realized that Indigenous healers did better work on fractures and with psychiatric illnesses. So sisters began referring patients with these conditions to the healers. In turn, the healers referred other conditions, such as infectious disease, to the sisters. Indeed, through partnerships negotiated on the ground, Catholic sisters and local healers played a large role in shaping the international agenda for primary health care, which became huge in the 1980s. Now, I'll add here that in the 1960s, Vatican II proved extremely important in influencing sisters' changes in mission because it reversed many long-standing and uncompromising doctrinal policies. It supported the idea of church as the people of God, and it also brought about a renewed emphasis on social justice. But as early as 1945, Mother Anna Dangle wrote that sisters' endeavors to heal would be of little help unless they were accompanied by an attendance upon basic social and economic structures. I suggest that nuns' growing attention to social and economic factors foreshadowed ideas of social determinants of health that we talk about today. Now, the 1960s brought other changes in the United States. Not only was hospital management changing, but the sisters were leaving their congregations after Vatican II. As one sister told me, sisters in habits were replaced by men in suits, and you can see that here. Some sisters went on to get master's degrees in hospital management, while others left to pursue theology or pastoral care rather than nursing. And of course, Medicare and Medicaid came in 1965, which changed everything in terms of financial support and hospitals' operating margins. And how much charity care could be provided was certainly being contested then due to hospital costs and growing insurance programs. Acrimonious debates among Catholics grew as large healthcare institutions in the United States were expanding. This is when some sisters chose to get out of the hospital business altogether because they could not meet their historic response to the poor, but others stayed. Now today, the Catholic Church sponsors the largest not-for-profit healthcare systems in the country, and you can see this. Talk about yesterday, Dr. Sam Orak talked about the giant in the room of Catholic healthcare in Uganda. Well, this is certainly an example of a giant in the room in the United States. Now, the Catholic healthcare reform debates of 2009 and 2010 show how religious issues, power conflicts, and crossover interests still permeated the healthcare system. Now, this shows a picture of Sister Carol Kean. If you got to see Bruce Compton's slide in an earlier session, he showed Sister Carol in Haiti, but here she's showing up again in Washington, D.C. This shows that religious issues, power conflicts, and crossover interests still permeated in the healthcare system in 2009 and 2010. On March 3rd, 2010, Sister Carol, who was president of the Catholic Health Association, was invited to the White House to hear President Barack Obama speak about his health reform plan. Now, you probably know this story. The Catholic Health Association viewed the legislation as going far toward covering more than 30 million uninsured people in the country. To the association, the bill was about access to care. This was an example of sister nurses engaging with the government once again. On March 17th, 59,000 more nuns joined the Catholic Health Association to support this legislation, asserting that it would make historic new investments in support of pregnant women. The sisters declared, "This is the real pro-life stance, and we as Catholics are all for it." That the sisters would take such a stand is not surprising. Again, they offered a different way of seeing the poor and oppressed in the many areas all over the world where they had worked. They saw the problems that developed when poor women could not get prenatal care. and the tragic misfortunes that often resulted when the sick were left alone to care for themselves. The sisters' actions gave a degree of inspiration and political cover to some congressional members who then came out in support of the bill. On March 3rd, 2010, President Obama signed the Patient Protection and Affordable Care Act, the first healthcare legislation passed since the Hill-Burton Act in 1946. The sisters' actions did not go contested, though, by the laity and the priests. So in closing, this presentation has shown that conflict and cooperation, entanglements, and crossovers have lurked in the background of sisters' work. In all of their hospitals in different countries, sisters had to adapt to diverse political, medical, social, religious, and professional circumstances to remain financially viable and ethically compliant to church directives. Tensions erupted among the clergy, the sisters, the government, and the lay public that persist to the present. But sisters' successes in finding common ground and building coalitions among disparate entities have provided valuable working models for how to blend the sacred and the secular. In November of 2013, Pope Francis issued his apostolic or exhortation, Evangelii Gaudium, and this was mentioned in one of the sessions yesterday. It was the joy of the gospel. He stated, "I prefer a church which is bruised, hurting, and dirty because it's been out in the streets, rather than a church which is unhealthy from being confined and from clinging to its own security." I think the sisters must have smiled broadly when they heard this exhortation, as it lent credence and support for what they have been doing since the 16th century. Thank you.
Thank you so much, Barbara. I think I join with everyone else in giving you a warm round of applause for everything that you said and really tied together what we've been talking about these last 2 days. We have a couple of questions, and I'd like to just start with the first one, okay? I'm wondering if there are significant numbers of sister nurses from Africa in the United States and Europe today in terms of reverse mission. If so, who are they and where are they?
Absolutely. And this notion of reverse mission is so true. What we're finding is that sisters in Africa and also in Asia and Latin America, but especially in Africa, are the missionaries back over to the United States now. Now, I have been able to interview the Immaculate Sisters of Mary. These were Immaculate Heart Sisters of Mary. This is a group from Nigeria, and they are working in the Midwest, where there are many Somalis have come to the Midwest. We have lots of immigrants, but again, they are working even in the Catholic schools now, and the Catholic other of the Catholic ministries in Minneapolis, so that there are fewer American sisters, and so that now we're seeing these sisters from other countries come over, and they really truly see themselves as missionaries to the United States.
Okay, very good. We have a couple of questions related to what you shared at the end about how the sisters supported the Affordable Care Act. And could you speak a bit about the conflict that emerged between Catholic Health Association, the Catholic Sisters, the U.S. Conference of Catholic Bishops over the Affordable Care Act?
Yes, and it was huge. Now, this act already, the Catholic sisters had worked with President Clinton on his healthcare plan earlier. And it really, in fact, President Clinton and Hillary Clinton, Mrs. Clinton, relied very heavily on the Catholic Health Association to see the kinds of things that they were doing in other countries and in other parts of the United States. What were they doing that we could learn from in terms of this universal health care? So they had worked with the sisters. Again, that bill never even got out of the Congress, so it was flat. It went nowhere. But then President Obama had seen that. And so he invited Sister Carol King and several people to converse and to consult on the bill. So, this bill was a combination of much input. I mentioned that the Hill-Burton Act, that the Father Joseph Shratala and others in the Protestant Health Association had actually worked with the government to help write the bill. Well, President Obama consulted with the Catholic Health Association in a very similar way. And but when it came time for it to pass, there were issues over whether they were going to actually support hospitals where perhaps some of these procedures were not such as that the Catholic ethical and religious directives prohibited, where some of these hospitals might still be performing some of the procedures. The problem was that sometimes by then there were a lot of mergers, and Catholic hospitals had merged with non-Catholic hospitals. And there was great concern as to what procedures are still going to be carried out. And these hospitals, where the Catholic hospital merged with the non-Catholic one. And the U.S. Conference of Catholic Bishops thought that that the Affordable Care Act did not protect the hospitals enough, and they were not for it. And it was very interesting. I was reading all of the newspapers and the different communiques coming out, and the sisters were very prudent and very prudent about how they talked about that. They would say, we don't disagree with the bishops. We understand this. We think we can deal with this later. We will deal with these issues later. Let's get the act passed first. And that's exactly what they did. And again, when President Clinton had one of the nuns with him when he was trying to get his act, he would have pictures. When he was trying to get his act passed, he would have pictures with him and the different nuns. Well, so did, and this you saw President Obama certainly did, but you saw here our now President Biden had that picture. And the Catholic Hospital Association, based up mainly of the women in the church, helped get that passed. I'm convinced, this is a non-Catholic talking, but I'm convinced that they convinced many of the members of Congress. Some of those members of Congress might have been taught by nuns in their schools. And the nun had, it's what I call, this religious authority and moral authority that I think really helped get that bill passed. Now, since then, there has been pushback. And even the Catholic Hospital Association is working. The Little Sisters of the Poor sued some of the sued the government over the Health Care Act. They've gotten some new laws in place that protect these Catholic hospitals. It's still an ongoing issue, and the whole problem comes a lot with the mergers. The Catholic and ethical religious directives are being rewritten all the time in order to provide guidance for this, but many of them they did a rewriting even after all of this. So yes, it was a great tension, and it was just very interesting to see. But the sisters helped get it passed. The Catholic Health Association, they helped get it passed. Now they're working on these other issues, and they do disagree on some of these things, and working to try and protect hospitals, Catholic hospitals.
And talking about the areas of disagreement, have you found in your studies and your research, are there any similar examples of sisters and bishops at odds over healthcare in the continent of Africa?
Well, I stopped studying Africa in 2000. So, and people will ask me that question. I go back to what was happening when I was interviewing the sisters who had been over there before 2000. And I think that there probably were some conflicts. The sisters were much more careful, though, they were very, I don't want to say more careful, but they were very careful as they were dealing with some of these issues. They worked during the Idi Amin period in Uganda. And so they had to be very, very careful with what they did. And eventually, they would work with many of the bishops, and in these conflict areas, they worked with many of the local Catholic bishops and even the Anglican bishops in Uganda. In Nigeria, there was conflict between Catholics working for the Nigerian government and Catholics working in Biafra. So there were conflicts even among Catholics So I think in my talk with the Sisters of the Immaculate Heart of Mary, I asked them questions like that, and they, they seemed to again, they knew this was a public audience, and so they were talking very much about how they got along well and worked very well together. So conflicts may probably do occur. I don't think that people are as apt to talk about that as much.
Mm-hmm. Yeah, and we've seen through this weekend, there's so many complex issues and angles to every situation that it really is a complicated situation, often more complex than sometimes we realize at first, or even in deep study. Another question that's come forward for you, Barbara, is in your research, have you found evidence of racism and racial exclusion practiced by U.S. congregations of women religious as explored in the ongoing research of Professor Shannon D. Williams of Villanova University?
Absolutely. I'm sorry, go ahead.
And then the second part of that question is, in what ways did American racial regimes affect the work of Catholic women religious involved in health ministries?
So, yes, the answer is yes to all of this. Mm-hmm. Now, once Medicare and Medicaid came, the law was you have to desegregate or you won't get federal money. So you start seeing Catholic hospitals all over the country desegregate. But in the Hill-Burton Act I mentioned, it gave federal money, but it did not demand desegregation. So Black hospitals, and when white hospitals were being formed in the early 20th century, they were segregated. So the Black hospital movement started its own movement. And we had black hospitals and Black schools of nursing all over the country, again, segregated. Some of the Catholic hospitals would admit African-American patients. Some of them did not. There were battles in Cairo, Illinois in the 1950s and 60s. The nuns wanted to admit Blacks and the local people. It was a southern Cairo, Illinois, sort of a southern city, and the local people absolutely pitched a fit. Well, the nuns won that battle. They were the owners of the hospital, and they certainly let Black people in. But there were issues of others that I read in the 1940s. Other Catholic hospitals, even though you read their public brochures and they say we're open to all, regardless of race, religion, or whatever. But there were instances of the nuns not allowing Black patients in. And doctors, many of the doctors, well, the doctors were white doctors, and the doctors didn't want the patients in. Well, the nuns acquiesced. That was not real common, but they did acquiesce. And it went to the newspapers, and that's how I was able to access some of these records. And I found some papers in one of the local historical associations. So this was in the 1940s and 1950s. So I do read many other chronicles. These are our primary sources, are the chronicles of hospital chronicles, where they do admit everyone, especially out west. It was much less, and certainly in places like Utah, even in Texas. Texas there was an African American population, and sisters in San Antonio did admit them. They also admitted Hispanics. So there were tensions, and then there were tensions between, okay, are you going to let a Hispanic woman into your religious order? And this did happen after Vatican II, but there were tensions with that. And in Africa, the pictures that I showed you, the medical missionaries of Mary did admit the Nigerian people into their into their congregations. But then there were also many, in fact, there are many African African religious congregations, primarily of African women who had formed their own groups. So yes, race was always an issue. And I remember when I read this about the Catholic hospital that refused admission, I emailed one of my very good friends and I said, Pat, look what I found. I can't deny this. I have to write about this. And she says, yes, you do. And I did. I will add that sisters now, I think, are leaders. And, by the 1960s, sisters were walking arm in arm with Martin Luther King. And many of the hospital sisters were not allowed to do that. Their local bishops would not allow them to do that. And there were sisters working in Selma, Alabama, who opened a hospital for Blacks because there was no care for Blacks. They admitted whites. It was but very few whites came, but it was a hospital for Blacks because Selma had no place to go. So that during the march to Selma, and when they had horrible Bloody Sunday, it was the Sisters of St. Joseph from Rochester at their local hospital in Selma who took care of John Lewis and some of the Black people who were harmed in the rioting. So it's a mixed bag, but certainly after the 1960s, it's a much more positive story.
Mm-hmm. And as you say, it's important to write all of that because we need to learn from history. And as has been said earlier on some of the other presentations, we make mistakes, and then if we can learn from them and then not make the same mistake twice, or learn from our history to how to respond to the realities and the challenges of our current world and our future.
Yeah, one of the points, in fact, as a historian of Catholic sisters, I work in private archives. It's not public archives. And I did feel an obligation to have the sisters read what I wrote. They never tried to censor anything I said. Ever. I did write about this situation, and the sister read it and never said a word, didn't tell me not to write it at all. Again, this was in 2010 when I was writing some of this. So I've had great cooperation. I did work with the sisters in Ireland who had been the medical missionaries of Mary, who had worked in Nigeria. And they were very hesitant to talk about their Nigerian experience. And I'd worked there for 4 days in the archives and worked about how hard they had done all this work and studied. And all of a sudden I found out that they lost their hospitals. I was devastated, after reading about all this hard work. And I was talking to the sister about it. And, they don't talk about it that much. It happened. It was what it was. So it's very interesting, the dynamics that go on with it when you're working with the religious sisters.
Mm-hmm. Well, I just would like to thank you, Barbara, on behalf of all of us participating in this. We're just so grateful for all your research, for what you have presented to us. And it looks like we've got one more question here. Let's see. How have Catholic hospitals and clinic ministries supported by the Church adapted to provide services recommended in the clinical practice guidelines in the treatments of conditions like opioid addiction, where contraceptive options are recommended to be offered to people who misuse opioids and also ovulate? So that question of women's health, how does the Catholic Church navigate the field of women's health with Catholic healthcare?
Well, I haven't studied a whole lot on the opioid epidemic. This is where the Catholic Health Association really is becoming more active, though. So whereas sisters supported Obama, they're really trying to negotiate and look at this. Catholic ethical religious directives prohibit that. And these directives are being rewritten probably even as I speak. So it's the area of women's health. Sisters will argue we are giving health to women. We're providing them health care. We're giving them prenatal care. They build on what they're doing to preserve life. And that's the message that's going out right now. So, but yes, those other areas, those are huge tensions going on. And the Catholic Catholic system right now in the United States is going through these many conflict areas right now. And especially as they remain such a large influence.
I don't know, Barbara, if you're reading these, the questions, but we just, Dr. Stan Chuilu, who presented yesterday, wants to thank you for the quality of your research in your book, Into Africa. He says, as a Nigerian, I was born after the Biafra War and reading your account was quite helpful. And I'd like to know what you think made the sisters so successful in delivering effective health care in that conflict situation.
You know, what I've heard, and again, in talking to the sisters, and the priests too, this was a work, you know, together, because priests were working with the sisters. Some people will say, you know, these sisters and these priests actually no longer were Irish. They became Biafran. And they had, by the time the war had come, they had integrated so closely with the people that they were working with, that many of them actually became what they became African. One sister, not in Nigeria, but in another one, actually relinquished her Nigerian or her American citizenship and became a Ghana citizen. So they worked very closely within the communities. This was no short-term assignment. These sisters came and they stayed for years and years. And many of them died there. Sometimes the priests were actually buried there. One priest was buried in Ireland, and the Africans, the Nigerians, this is before the Civil War, but they went to Ireland and brought his body back to be buried in Nigeria. So I think it's this notion of really working with the local members of the community and learning, becoming embedded in the society. The sisters in Tanzania worked with Julius Nyeri's program. Sisters in Ghana worked with Nkrumah. You know, they worked, and many of these African leaders had, I mean, they were more or less, I don't want to say socialistic views, but they were views that involved the whole community. And the sisters really became involved in that. I think that's what happened even in Latin America. The sisters were becoming so ingrained with their local communities. Got some of them killed in Latin America, but in Africa, they really worked very hard, so that when they were kicked out of the country, it was terrible, and it was really heartbreaking for them, and it was hard for the sisters who were left behind, the Nigerian sisters who were left behind, but they had been well trained, and they did it. And now if you look at pictures of Catholic hospitals in Tanzania and Nigeria and Uganda and all those places, they're run by local African doctors and nurses and midwives and obstetricians and all of that. Mm-hmm.
Yeah, and I think those are good. You've brought up a lot of good examples about how we be culturally sensitive, make connections between traditional medicine and Western medicine, be aware of the people and train the people of each area so that they can be empowered to undertake the services that are in need in the area. So I think these are all good examples, and your studies really reflect what we've been talking about this weekend. I'd like to turn the camera over to Dr. William Cavanaugh to wrap things up. And I just want to again thank you, Barbara, for your presentation, and everyone who participated, and all these good questions that have been brought forth for us. Thank you.
Mm-hmm.
Yeah, thank you, Barbara. That was really a terrific way to bring the conference to a conclusion. We had a conference in Igbo territory in Enugu in Nigeria in December of 2019, and the faith of the people there is really palpable. We were at Bigard Memorial Seminary, which is the largest Catholic seminary in the world, with almost 900 young Igbo men in formation there, and you can kind of see that the faith of the region is in some ways a legacy of the work that the sisters have been doing there for decades. So that was really interesting, and the way that your presentation connected the North and the South, I think was really a wonderful way to bring the conference to a close, because that's part of what we've been dealing with all weekend, is seeing how closely intertwined the global North and the global South are. and how closely intertwined the body and the soul are in all of these matters. So thank you so much for a terrific keynote presentation.
And I'll just add one more point about the legacy of the sisters. When the Rockefellers started, they opened hospitals and institutions all over the world. And especially with primary care and preventive care, what did they do? They looked at the work that the Catholic missionaries had done in all of these countries when they started devising their own programs. So there's a great legacy there.
Yeah, that's wonderful. Yeah, and of course the Hilton Foundation is kind of carrying on a lot of that work, supporting the sisters as well. Yeah, so thank you, Barbara. Thank you, Sister Mary Jo, as well. I want to thank all of the speakers and the moderators that have made this conference work. It's been arduous. We were 10 hours on Zoom yesterday and 8 hours on Zoom today, but very, very rich, and a lot of hard work went into it. And I think a lot of good ideas and good work is going to come out of it as well. Thanks to the members of the audience for your attendance as well. And finally, I want to thank the staff at the Center for World Catholicism and Intercultural Theology at DePaul, who make all of this run. I want to thank my fellow faculty members in the center, Mike Buddy and Stan Chu-Ilo. I want to thank our student workers, Finnegan Chu and Elijah Gray, and above all, the people who really, really make this conference work and made it work in a way that they haven't had to make it work in the past. Had to learn a whole new skill set to do this online. Karen Kraft and Marlon Aguilar, who have been attentive to this for months and have been in communication with the speakers and have run all of the technical issues and everything else, all of the logistics of the conference that made it work. So thank you so much to Karen and Marlon as well. And thanks again. All of the talks for the conference will be posted on our website within a couple of weeks. The essays from the conference will be available in a volume eventually. And hopefully all of this good work will bear fruit. Thanks, Barbara. Thanks, everybody, for coming, and have a good evening.